Well, thank you all for being here this morning. Anytime I'm invited to come and speak about caregivers to an audience that is interested and motivated, I'm very happy to come, especially at 7:30 in the morning on a Friday. So I'm going to follow along from Dr. Sinha's talk. He provided a really nice foundation for my research. And what I'm going to speak about is I'm going to look at how a healthcare system is delivering care through the eyes of family caregivers. So how they're seeing care and how they're experiencing our care system, and then provide some suggestions on how we might do things a little bit differently, and finish off with what I'd like to see some changes made, hopefully before I retire, maybe. So right now, we have a very fragmented system of care. Dr. Sinha talked about caregivers being navigators. So we have acute care environments, rehabilitation environments, we have community care organizations, and the communication between these different care contexts isn't very good. Things are improving as we move along, but from a family's perspective, they become the ones that have to navigate and support their family member as they're moving across these different care contexts, and that can be quite stressful and challenging for them. We are also very proud of the concept of patient-centered care and moving the focus of care to the needs of the patient. From that perspective, families are typically viewed as someone who is also part of the support network of the patient, but they don't necessarily address the needs of the family themselves. I think Dr. Sinha and the work he is doing is very exceptional and not really standard to what we're seeing across the country. We also have this wonderful privacy legislation in place which helps to protect patients, and their information about their illness and conditions are not shared. Of course, it's kept private, but one of the challenges in situations where that information is not shared with the families are organizing and supporting somebody in the community, but don't have a full understanding of their medical condition or their needs because of the privacy legislation. And the big thing for me, and you're going to see in a bit, that I do a lot of work in stroke care, and we've done wonderful things in stroke care in Canada. And the thing for me is that it's not standard clinical practice to prepare or support family caregivers no matter where you are, no matter what city you live in, what healthcare organization you're working with. It's not standard practice, and I'd really like to see that happen. So, it doesn't matter what population you're caring for. We know in the literature that caregiving is quite universal in the effects that it has on the caregiver. Dr. Sinha talked about this as well, but we know that many caregivers experience stress, burden. There's an impact on their own mental health, their physical health, their quality of life, their ability to engage in activities that are of interest and value to them. It affects their work life, which we've heard about. So there's many different ways that caregiving can affect the health and well-being of caregivers. We also know that if a caregiver isn't doing well, or if they're crying when they're coming in to see you, that can really affect the care and support they're providing to their family member. So I'm going to use stroke as an example, and I've been doing stroke research for over 20 years now. And I think it's a great example because it really does touch on the different care environments. So a person has a stroke, they go to an acute care hospital, then they typically come to a rehabilitation facility like Toronto Rehab, and then they go and receive care in the community. And the families are supporting the transition across those care environments. In addition, stroke is a leading cause of adult disability that's associated with physical, cognitive, and emotional changes, and the family members are caring for somebody with all of these things going on. And we also know that family caregivers are providing support to somebody during the stroke event themselves, during acute care, supporting their recovery, rehabilitation, and then their return to community living. So I'm going to introduce you to somebody that I was able to speak with. She's actually from Northern Ontario, and what I asked her to do, and we've done this with a number of different caregivers, but I've chosen Louise as a specific example, but what I asked her to do was to share her story about her experiences with her husband's stroke, right from the stroke event itself, right through to where they are now, 3.5 years post-stroke. And what I've done from our discussion is I pulled out some keywords that I thought were of interest. So she used language such as, "It was a blur, it all seemed so fast," with respect to the emergency department and acute care stay. She used words like she didn't feel like she was respected or supported as a family member to someone who had had a stroke. She found it to be overwhelming. She needed to understand what had happened and what was going to happen next. And even at that point, when she started to think about discharge back to the home environment, she was panicked. So these are some of the words that she used during the acute care stay. When she moved to the rehabilitation hospital where her husband was cared for, things were changing. Staff were great. They were supportive. The family was supportive. Neighbors were supportive. People were doing things for them back in their home environment. They were getting help with everyday activities. So this is what it looked like in rehab. And then when she started to think about, now it's time to take him home, now she's panicked again. She felt that she was not prepared. She needed to be prepared emotionally for how to care for this person. And she felt that she needed some written instructions because people were telling her things and she wasn't remembering them as she was preparing to go home. When she first went home, she remembers really needing more help. She needed to do things like go grocery shopping and pay the bills and do things like that, but she didn't want to leave her husband at home and he wasn't really well enough to go out with her. So she needed more help. And she also started to acknowledge, I also need time for myself. I need to take care of myself, and I don't have time to do that. Now, 3.5 years later, so her husband had aphasia, so difficulty communicating. So this added another wrinkle, and I don't know if the family was well enough prepared when I hear Louise's story. But what happened as a result is that because the family members didn't know how to communicate with somebody who had difficulty communicating, they didn't do it at all. So they started to ignore him and leave him out of conversations and just leave him, in some situations, in another room by himself. So they had these horrible experiences. It was very emotionally upsetting for both of them. They were also starting to reflect on how really they weren't going to have the future as they had intended. So their plans that they had for many years were no longer going to be in the cards. So they had to reflect on that, and there were many, many emotions associated with that. But there were some positives. Their social network kind of fell apart after the stroke, but they were recreating a new network. They were interacting with people in similar situations. Her husband was going to exercise programs. She herself was engaging in volunteer activities that she found valuable. The future was uncertain, and she still talked about the possibility of more decline and what that was going to look like and what the implications were. So I like Louise as a story because you can see how things are changing from the time the stroke happened to 3.5 years post-stroke. It's not a stagnant condition. There's a lot of changes happening, and how do we think about that from the family's perspective? So does it come down to timing? So we've interviewed caregivers in many different situations, many different research studies, and we had this one study where I thought it was really interesting that different caregivers were talking about this one sort of standard educational resource that they received. One caregiver received it during acute care and felt that it was overwhelming. Another caregiver received that same resource when their family member was back in the community and thought it was excellent. So one resource perceived differently depending on when they received it. So that's interesting. When we talked to stroke survivors, they felt that when they left the hospital, the doors were closed. There was no more outreach, they were left on their own, and this was a problem. When we talk to healthcare professionals, they typically say that they don't know when families are ready to receive education or support. So there really is something about timing. So during my postdoc, working with Monique Gignac, actually as a postdoc here at Toronto Rehab and at U of T, we developed what we call the Timing It Right framework. So this idea of timing, we're trying to understand better. So it is a comprehensive 5-phased approach to support families from the hospital to the home. It emphasizes the timing of support needs, so trying to give families the support they need when they need it across the illness trajectory. And the central premise is that if we can address phase-specific needs, we can enhance families' preparedness, ease transitions across care environments, and minimize negative outcomes from happening. I often have therapists coming to me and saying, "Jill, will you give me a measure of caregiver burden or distress so we know when it's time to intervene and support caregivers?" And I've never given a measure out, and my standard response is, we know it's stressful. Why are you waiting for them to have a hard time? Why aren't we more preventative and trying to support them from the get-go? So that's been my standard response. Just to give you an insight into the phases, the first phase we call the event diagnosis. This is happening in an acute care hospital. It's the time when the person has had a stroke, but nobody really knows that yet. The goal is diagnosis and survival. And so families' needs are very specific. They don't want to know about secondary prevention at that point because, of course, it's not relevant. Once the person has survived the stroke, families move into a phase called stabilization. I sort of view this as a time where families take a breath. They go, okay, what's next? Then we moved into the preparation phase, and this is when they're preparing to take their family member back to the home environment. What changes do they need to make? What training do they need to support this person back in the community? And this could be from either acute care or rehab, depending on where they're going home. The next two phases happen in the home environment. The implementation phase we also call the figuring it out phase, and this is where families take everything they've learned in an inpatient context, either rehab or acute care, and they try to apply it to their home environment with narrow stairways, rugs, clutter, and all of this, and somebody with a stroke moving around. Oh, something's happening. Thanks for the heads up. We're ignoring it. All right, so that's the implementation phase. And after they sort of figure it out, how to live at home, we see what Louise was talking about 3.5 years post-stroke, and that actually happens much earlier. But they start to say, okay, now we have to start thinking about, maybe we want to get involved in social activities. Just go away. Maybe we'll go and I switch to the next slide. There we go. So they move into this adaptation phase where they're really thinking about the longer term living with stroke. And again, the idea here, it's not letting me advance now. It's not happy. Yeah. So the idea here is that families have different needs for support across these different phases. There it is. Okay, you're doing it now? Okay, so anyway, I just want to say that when I talk about support and the different types of supports needs, I like to build on what social support theorists conceptualize as support, and it's important to look at this. So we know that support is emotional. There's an informational piece of it. You learn things in a support context. They also need tangible assistance or somebody helping them organize services, for example. They also need training. Maybe they need training in communication like Louise did. How do you communicate with somebody who can't communicate? And the important thing that this world brings, the support brings to us is this concept of appraisal. Which we don't think about typically in the caregiving literature, but when you look at it, this caregiver, it was another wife in another study caring for a husband with aphasia, and she said that, tell me that I'm doing things right, and that's what I didn't get. So that feedback as to how they're doing as caregivers. Okay, so I did that, or did you do that? You did, okay. So the good news, so I've been doing this for a while, and the good news is that these ideas really resonate with the Canadian Stroke Best Practice Recommendations. These ideas of looking at timing when we're talking about education and support has been incorporated into the guidelines. So how do we use this information to actually do something to improve the outcomes and the well-being of family caregivers? One possibility is the Timing It Right Stroke Family Support Program, which I'm going to describe to you briefly now. All right, so we had this idea of wanting to develop an intervention using this framework. So we said, okay, maybe there's a module or a chapter or something for each of the phases. We did some qualitative research with family caregivers and healthcare professionals like Louise, and caregivers like Louise, where we said, walk us through from the stroke event itself right through to where you are now. What do you need? When do you need it? We got the healthcare professionals' perspectives. We put that together and we created an educational resource. I'm not going to go through all of it because I think I'm running low on time, but this is essentially what it looks like. So from a family's perspective, they can open up the guidebook and say, okay, where am I now? Okay, my family member has just had a stroke, so I only want to look at this. And then they can work their ways through. If I were to present the guide on an edge, the thickest chapter, you've gone a little too far, it's just going, okay. The thickest chapter would be chapter 5, the first few months at home. That's where their needs are most. So that's the thickest, that's the most. Okay, we can keep going. So then we start to think about, okay, again, I've talked about our fragmented system of care. How do we deliver an intervention like this that crosses care environments? So we looked at what the caregivers told us, and they said they wanted one person to provide support. They wanted follow-up after they left the hospital. We looked at what others had done. Joan Grant and her colleagues had done a lot on telephone support for families, because again, we've already heard that they can't go and leave their family member and go and join a group. There has to be a way that they can do something easily. There's more online possibilities now. But the idea here is that telephone support was a viable option, and the other models in the UK and in Quebec is they had one key person who was responsible for supporting the care of somebody in different care contexts. So we created what we call a stroke support person, who is one individual who interacted with the family during acute care and then continued to provide support afterwards as they were transitioning home by phone. Okay. The stroke support person, many of them have been occupational therapists, although I'm not an OT, I'm an occupational science. I'm kind of a fake. I'm probably somebody who didn't know about OT when I was going to school, and I probably should be an OT, but I'm not. So OTs like this idea, nurses, social work, and essentially we are looking for people who have expertise in stroke management and care options. So what they do, and what we heard Dr. Sinha talking about a little bit, is we try to touch on all the different elements of support. Every time we interact with the families, we ask them how they're doing, because we need to ask them how they're doing. They might cry, and you have to be prepared for that. We try to provide them with any information that they need. We also try to give them a little bit of insight by using language like, other caregivers have told us at this time that this information might be valuable. Would you like to talk about it or learn about it? So we do a little bit of that. We provide some tangible assistance. We definitely try to fill in the navigator role. We know that navigation is a challenge, so we try to provide some insight there. We try to give them feedback, so we do use language like, it sounds like you are doing well, so we try to give them that feedback. But please note that the stroke support person isn't trying to replace any services or things that are available, but they're helping the families find appropriate services and support and know who to talk to. If you've got problems with communication, you've got to talk to your speech language pathologist. That's about it. And this is what it looks like. Again, giving families the support they need when they need it. And from a research perspective, we did a multi-site randomized control trial in 13 cities across Canada. Still working on the papers, have to get time to write. But essentially what we learned is that there's a lot of variability in caregivers, and that variability really affects what they need for support and how they engage in support interventions. Their personal characteristics. The healthcare professionals in the room would say, yeah, we definitely know those caregivers who are the ones that are, going to ask us questions and get the support they need, and there are some that are not, and they need more help. So it's their personal characteristics, this idea of insight. Some may have really no idea. In the world of stroke, I think families typically think that rehab is going to fix their family member. They don't really understand that there might be long-term consequences of the stroke. There's also a lot of variability. Actually, just go back, sorry. There's variability in their own support network. So some people have really good support networks and some don't, so there's complexity there. What we do know is that caregivers who need more support engage and benefit from our intervention. Next steps, we actually have a PhD student right now who's looking at trying to understand transitions and phases in the context of dementia caregiving, so to understand that and tie that to their support needs a bit better. All right, so now I am where I'd like to see the healthcare system in, maybe by the time I retire or maybe my next big trainee. Oh my goodness, they really don't like me today. So I'd like to see a coordinated system of care where a caregiver is benefiting from somebody like a navigator. So they don't have to be the navigator anymore, but they're benefiting from a navigator to help them in their role. I'd like to see us move from patient-centered care to family-centered care, because family-centered care takes it to the next level where the family's health and well-being is also considered and is prominent in the way care is delivered. We need to really revisit this privacy legislation and figure out how the families fit and don't fit, and what information can they have and can't they have if their caregiver role is valued and recognized by our country. I'd like to standard clinical practice to prepare and support family caregivers. When we're looking at report cards that hospitals receive, if it's not standard practice to support family caregivers, they're not going to get their extra money, or however the funding models work. Really, the idea is giving the right support at the right time. And I will leave it with the next, if we can go ahead. I don't think I can you? I'm going to leave it with this. There's the author of For Better, For Worse. Her stepfather, I believe, had a stroke. So she did a whole series of comic strips. And this one is essentially talking about caregiving being a job 24/7. And this caregiver is having a break, having a coffee break, when a speech language pathologist is actually in with her family member. So that is all I'm going to share with you. And I'm going to pass it over to you, Dr. Ditka.